Without wasting much time, I'd like to call upon and invite my teacher from Arvind Eye Hospital, Dr. Naresh Babu sir, who is the head of Vitreoretinal Department at Arvind Madurai,
Sure.
for the keynote address.
Yeah. Thank you, Jyoti. Now, it was a medical retina session, but we'll be discussing a surgical complication. But anyhow, to fulfill that thing, actually, we'll be talking about the medical treatment of a surgical condition. So today we'll be talking about how we are using methotrexate in case of surgical complication or preventing the PVR and the hemorrhage. So we all know that methotrexate is folate antagonist. It has got a lot of indications in ophthalmology, especially in case of lymphomas, intraocular lymphomas, primary lymphomas. But we have been now using it for both regmental retinal detachment as well as for the PDR cases where there is a subsilicon oil hemorrhage. The dose varies. It can range from 250 microgram to 400 microgram, and the mode also varies. We give intravitreal injection, but there are people who use the methotrexate in infusion, or somebody will fill the eyeball with the methotrexate 400 microgram, wash it, and then fill it with oil. But we go for 400 microgram, 0.1 ml intravitreal injection. So we'll be discussing basically the PVR, how to prevent that in case of post-retinal detachment surgery, because PVR, that is proliferative retinopathy, is the one which causes a redetachment in most of these cases. And the chances of PVR is as high as almost 40% in case of giant retinal tear. So nobody wants a retina to redetach after its reattachment. So these are the various types of PVR. And we know the role of methotrexate in RD, so it's a very safe adjuvant. And it has reduced grossly the redetachment in case of PVR cases. So this is basically our work on methotrexate, where we have injected intravitreal methotrexate at the end of the surgery, and at the end of every week for 3 weeks we have injected. So most of the cases received 3 injections, and we divided into 2 groups, one receiving methotrexate, the control not receiving methotrexate. And in the control group, we found that the redetachment is very significantly high, but whereas in case of the cases which underwent injection, the redetachment is less. Even if there is a redetachment in case of methotrexate group, there is very less chance of macular redetachment. So the outcome with a serial injection following cataract surgery is good. So this is our final, the success rate with methotrexate. So in conclusion, it helps in the better reattachment of retinal detachment. The mean visual gain is much better in case of methotrexate group. The other thing is the methotrexate where we use extensively is in case of subsilicon oil hemorrhage, because most of the cases which we operate have got some sort of renal problem or a cardiac problem where they'll be on blood thinners. So in spite of achieving complete hemostasis at the end of the surgery, there will be some amount of subsilicon oil hemorrhage. Sometimes it's so massive, so that leads to severe angle closure glaucoma, sometimes PL negative eye. So we have started using this accidentally, and we found that it has got antiplatelet property also, so it helps in lysing the clot. So this is the purpose where we wanted to inject. So in all these cases, at the end of the surgery, this is a series of 44 cases. We don't have a control group after we started this. So all these cases had subsilicon oil hemorrhage, and on POD1, where we have injected methotrexate in all these cases, again a serial injection. And we found that the vision improvement is better in this case. As I told, the dose is the same. So a few cases, this is the pre-op case. On POD18, when the patient came, this was the picture actually. Usually what we do is we go for removal of silicon oil, and then we wait for the clot to lyse and re-inject oil. But this patient underwent methotrexate on 8. This is a second injection on 16th day, improving to 2/60. Third injection, improving to 3/60. So at the end of 45th day, literally the entire clot lysis, no surgery done, only with the methotrexate. This is the second case, pre-op fundus. Very good surgery, but some amount of pre-rectal hemorrhage. So with the 3 injections, the complete disappearance of the the hemorrhage, no formation of membrane, no redetachment in this case. Vision stabilized at 5/60 at the end of 5th month. There's another case where you can find a traction rectal detachment. Okay, not much. So this case with the hand movements, this was when the patient visited on POD 15, hand movements. Usually it is disturbing for both the surgeon as well as the patient. So after serial injections, this is the final outcome in this case. So at the end of 45th day, complete or near total resolution of the hemorrhage. But a lot of evidences are there, especially for these cases. But people have mostly used bevacizumab for this case. Very rarely people have used methotrexate. And the incidence also very high, especially in our population because of the blood thinners and other things. So we found that by using methotrexate, it reduces the rate of redetachment as well as it improves the visual acuity in these cases. So, but for PVR, we have got a lot of evidences. This is the first evidence which we'll be publishing shortly for cases of subsilicon oil. The other molecule which we have started using is topotecan, which is usually used in retinoblastoma. We use a low dose, that is 30 microgram. The only problem with the topotecan is it's a very expensive drug, and second thing is its shelf life is very shorter. So in case we open, we have to immediately use, and sometimes it's difficult for us to convince the patient. So we have got very few cases with topotecan, just 5 cases we have done. So we'll be comparing that with what you call methotrexate. So this is what I wanted to say. A pre-op picture with the immediate post-op hemorrhages resolving completely. So we found that this is quite effective, especially because of its anti-proliferative as well as because of its platelet, that is clot lysing property. And a dose of 400 microgram, its safety has been established long time back when we were giving it for lymphomas. And it has got a definite role in preventing recurrent detachments. Now many people have started using it. And it also resolves rebleed as well as prevents reproliferation in case of silicone oil filled TRD cases. And we found that it really enhances both anatomical as well as the functional outcome in case of diabetic vitrectomy when we inject serially. Thank you.
Thank you, sir, for that wonderful talk. Sir.
Yes. Check.
Naresh,
Yes, sir.
is it necessary to give 2-3 injections? With the first injection itself, you might have got the full result.
Sir, actually, in case of PVR, it's not going to start immediately.
Yeah.
Usually, it's going to start after 2 or 3 weeks.
Yeah.
So, the first 2 injection, maybe it aids in prevention.
Yeah, PVR, okay. I'm talking about diabetic.
Sir, actually, every time we inject, we found that there is a gross reduction in the size of the clots.
So every week you inject?
Every week we inject.
Inject and then...
Yes, sir. The half-life is also very short in this ultravitreal.
Yeah. Half-life. Then have you tried this? I'm asking you. We have some of these, very clean cases we do.
Yes,
and they keep coming back with us with this post-operative vitreous cavity hemorrhage.
Yes, sir.
We give sometimes bevacizumab, we do lavage. We don't want to inject oil because oil, the quality of vision. Suppose 6/9 vision is having unaided,
yes,
but that fellow will keep coming. We don't know why. Everything lasered, everything okay. Very rarely we have patients like this. Now, in these sort of cases, do you think methotrexate intravitreal have any effect?
Sir, not only for RD, we have got elective staged surgery for TRDs. Like where the retina is good after the membrane peeling, but wherever there is bleeding, in such case, we inject methotrexate, gas, lying for a prone position for 10 days, then we call them back. In most of the cases, there is a complete lysis of clot. If needed, in such cases, we go for silicone oil injection. Otherwise, sometimes it helps actually. But we call it a stage surgery for TRD. We don't bother about the hemorrhages happening intraoperatively. Inject methotrexate, call after 10 days, assess, then re-inject oil. But we explain the patient that it's going to be a two-stage surgery for them for even TRDs.
Sir, any experience on using it for subretinal blood in diabetic retinopathy? Some patients who have
Yes.
fleet.
No.
You
No experience. No experience.
injecting subretinal.
No, I understand. Intraoperatively.
Yes.
We have not done.